Okay, so when we were talking yesterday and I showed the video um, of, kind of them prepping a horse, and then just wanted to show like an example of field anesthesia to give a comparison of two ways that a horse is going to be anesthetized. And again, choosing a protocol and how you're going to do anesthesia, a lot of times it's going to be dictated by the procedure. Some procedures can be done at the farm with a mobile vet, and some are going to be better done in a hospital. Now, in a hospital, you can do sedation, you can do TIVA, you can do full general anesthesia. At a farm, obviously, you're limited via equipment and obviously the support that the horse needs. Again, you're not going to do a colic surgery at somebody's farm. That's a very advanced procedure. But like laceration repair, teeth floating, castration, um, some simple procedures can probably be done on site if need be. And I talked about how to prep a horse for surgery. And then, so when we talk, I mentioned all this yesterday or the other day, but standing chemical restraint is kind of, it's a deeper level of sedation. And sometimes you'll give a light sedative and then give an intravenous sedative. Standing chemical restraint is not general anesthesia because they're still able to stand. They're still able to have some of their reflexes. They're just in a very deep level. So how do you know which, slide 13 here tells you, how do we know a horse is ready? How do we know so they're in a stock and they need something to help kind of keep them corralled. So usually they're put in stocks like this that was in the picture. And this is if you don't want general anesthesia. So, you're only going to do this if they don't need general anesthesia. The horse should be standing, but they want the droopy lip, wide base stance. So again, a horse is usually pretty straight up and down. They want their legs wider. Sometimes they're going to sway a little bit. Initially, we just don't want them to completely fall. And one thing is they have a lack of interest in what's going on around them. I don't know if you can appreciate yesterday in the Dr. Pole video, that horse, before it fell down, it was kind of wide base stance, its head was down, but it wasn't like ears up looking around. It wasn't interested in what was going on around it. It was falling asleep. So, and especially when they start to lower the head and neck, because again, normally a very alert horse has the head up, ears up, looking around. These are all signs, and you need to be able to describe, how do we know when a horse is ready? Now, anytime, I've warned you about this in small animal, and you may have noticed this when you guys did your sedated patients, your dogs for radiology, but sometimes they can look very, very asleep, and then someone drops something, or especially the radiology machine, it clicks and it beeps. And sometimes they can throw up their head or look around. So sometimes they can look very asleep and they can still react because, again, some of the anesthetic drugs make them more sensitive to loud noises. And you always have to be really quiet. It's probably one of my pet peeves when I've worked in surgeries, is that people just come in the room or people are around a sedated dog and they're talking really loud and laughing loud and dropping things. You just want to be as quiet as possible because any sudden sounds and movements can react. So you have to be very on guard, paying attention, and usually if you're going to do this, usually somebody is going to have additional sedative because a lot of times in a standing procedure, and you guys will learn this when you get into practice, sometimes a doctor tells me, oh, this is only going to take me 20 minutes. And an hour and a half later, we're done. I mean, if I had a dime for every time that's happened to me, I would not have to be teaching because sometimes things are unpredictable. So normally you don't want to have to be running for more drug. And so normally if you're going to do standing chemical restraint, You know, sometimes it's unpredictable, more sedative having it nearby. And if I look in this picture, which I showed you yesterday, um, you know, this is, they're in the stocks. You can't see her hands here. There's an extension set, but she is ready to give more drugs. She's watching the procedure. She's watching the horse. Like if the heart rate starts to come up, if the horse starts to move, you know, she can give a little bit more drug IV. And again, there's going to be different doses for these drugs based on light sedation, heavy sedation, like the doses you guys used in radiology for your dogs um, to go IV to sedate them for radiographs was much higher than if you're going to sedate them potentially for a nail trim or, you know, a blood draw or sometimes even a pre-med. So you have to pay attention to the dosing. Now, if I go backwards, because there's notes under here, usually the drugs like the alpha 2s, sometimes butorphanol, sometimes acepromazine, those are drugs that we know that they can kind of react if they hear sounds, and that's when you want to be more cautious. One thing that you can do, and there's not in this picture, but you noticed it in the first video yesterday, is sometimes what you can do is take a towel and cover their eyes. Now, the only downside to that is I like to look at their eyes to kind of help me predict. Horses' eyes don't roll predictably like dogs do. Like a dog's eyes tell me a lot during anesthesia. I rely on being able to see their eyes quite a bit. So a horse, it's not as predictable, but sometimes people will put a towel and tuck it in their halter so it keeps it dark and it helps keep them a little more sedate. And you can put cotton in their ears. You just have to remember you put cotton in their ears. We've done that for dogs, like when I've used oxymorphone, which was a drug like hydromorphone at Purdue. We put cotton in their ears, and I usually put a piece of tape on their head, and I said cotton in ears. So when I go to wake that dog up later, I don't forget that I put cotton in their ears. So sometimes we put a piece of tape on their head if we have to do something before we wake them up. It was kind of a little technique. So if I see that piece of tape and I'm like, okay, I got to pull the cotton out, because sometimes it'll help muffle the sounds, and you can do that as well. Okay, so when we do induction, again, it's a different technique than when we are doing sedation, and it's different technique than if we're inducing a dog. So you want to render them unconscious. You want to get them from standing to, you know, a recumbency pretty quickly. We don't really want them going through an excitement phase. And we want to get them down as quick as possible with minimal injury. So induction is a bolus technique rather than propofol is to effect. So everyone needs to know what we do is the induction drugs that you calculate, you're going to give all of it. You're going to bolus them. And when I mean bolus, you are going to give them fairly quick, but kind of steady. But usually you give all of the drug that you calculate. And most of the time we have access to more drug if we need be. But you know, when you calculate the induction drugs, you want to give it. I'm going to talk about a drug called guaifenesin. If you remember when we talked about drugs, anesthetic drugs last term, I kind of skipped over guaifenesin. But guaifenesin is a muscle relaxant. And if any of you have taken, I don't know if you've ever taken a drug called Mucinex, if you have a, you know, like if you have a deep cough, guaifenesin is an ingredient, and you know, it's in Mucinex, and it's in a lot of those like sinus medication, usually like cough medication, I should say, not really sinus. And what guaifenesin does is it's a muscle relaxant, and it helps loosen up your airway muscles. so you can expectorate or you can cough up the mucus. And that's kind of, so the dose in Mucinex, obviously, of guaifenesin is not an anesthetic dose, but it is, guaifenesin is used in large animal to enhance muscle relaxation. So normally they might bolus xylazine and ketamine as like boluses, and then give some guaifenesin to effect. And as the horse gets more relaxed, they can stop giving the guaifenesin. So, but guaifenesin, and everybody hear me right now, because guaifenesin will be on this test. Guaifenesin is not an anesthetic. Guaifenesin is a muscle relaxant, and it's used to enhance the relaxation. So it's not going to depress, you know, the CNS. That's why you give, that's why you give the xylazine and the ketamine, and you just add guaifenesin to effect to cause relaxation. So normally you can give, a lot of ketamine is used, so you can give IV ketamine with either Valium, or you can give xylazine, ketamine, and then guaifenesin. And there's a couple different ways you can do it. You can give guaifenesin IV at a certain amount, see some relaxation, and then follow it by the ketamine. Or you can give the ketamine first and then give the guaifenesin. It's kind of up to the doctor and the protocol that you're doing. But I mostly want you to know that it is given as a bolus induction. Now let me go back a second. One thing that I want you to also know for this section is there is something called triple drip. Sorry, I'm trying to. Okay, so in horses, they use the common combination is called triple drip. You know, like we talk about kitty magic it's not horsey magic, but we call it triple drip. And this drip is typically ketamine plus a tranquilizer, either diazepam or xylazine, and guaifenesin. And, you know, so 3 drugs, they call it triple drip. And they use some combination and some form to anesthetize the horse. Now, if you go to work with horses, you'll learn their protocols. I don't usually have you guys memorize all different combinations, but this is just a common, if you hear someone say triple drip, you do need to know that for the test, and that is this bolus induction combo. But again, guaifenesin is not an anesthetic, it's just a muscle relaxant. Now, when you give the bolus, one thing that you're going to want to do, and I've told you, anytime you induce anesthesia, that's a dangerous time, recovery is dangerous. You have to get some vital signs checked. You are not going to feel a femoral pulse. So their femur is up much higher in their body. So you're not going to reach your hand under their back leg. Usually in horses, you're going to palpate a peripheral artery. And that's the quickest way to find a pulse. Now, I'm going to talk about this again, but there's a transverse facial that goes right along the eye, ventral to the lateral campus. There is also, they've got their big masseter muscle, their big cheek muscle. There's a mandibular artery right under that jaw. So you can just literally put your finger on that bone and feel an artery. But the big mistake that people make, if you've not worked with horses, and maybe you guys have found this because I know you guys are going out to the farm now with horses, if you go to take their heart rate, sometimes I have students going, oh, I can't find their heart rate, and I literally grab their hand and stop. I mean, their heart rate is around 30, 40 beats a minute. It's slow, so you have to be patient. If you keep going like this, you're probably never going to feel the pulse because you got to give it a second. So because their heart rate is much lower, their pulse rate is lower, it may take a minute to find it, but somebody right after induction needs to verify that they have a pulse. And that's when you guys get into surgery, when you induce, somebody's got to get their hand on that heart or a pulse and verify that it's an adequate beat at some point. Because I've seen people go 20 minutes in to an anesthetic procedure before they take a pulse. And I'm like, we got to do that right off the bat, verify that the patient is okay. Now, when we position them, and I'm going to talk about this, remember they have to be on a padded table. So any superficial nerves and superficial muscles need to be padded, no hard surfaces. And normally when a horse is in lateral, this is very strict too. When they're in lateral, if their leg is relaxed, and hopefully you guys are watching me on video, their legs would kind of cross each other. Their legs need to be parallel. And normally what they'll do is they'll take the one that's closest to the table and pull it forward, and the one on the top pull it back, like in a scissor formation. And that's going to be better on blood flow and the nerves. The problem is if this limb lays on this limb, it's putting pressure on the down limb. And also, if you cross their limbs, it makes it also harder for them to breathe. I mean, if you cross your arms and you inhale, but you open up your legs or your arms and you inhale, it's a lot easier. So you want to make sure they're separated with padding. So normally people put padding or something and kind of slightly separate them so that they're not laying on each other. And again, if you do induction, this is only giving you 10, 20 minutes with that triple drip. So normally we're going to intubate and do this. So here's an example in this picture of this horse is down in an induction stall. And if you can see where they've put these straps, they put these hocks, is right near the fetlock joint. And that's, again, where above the hoof where it narrows, that's the fetlock. And then they hook them up to a hoist in the ceiling. And so somebody supports the head and tail. So now this horse can be hoisted and moved onto the surgery table. And again, this does not hurt the horse as long as you put these in the right location. I know that's a lot of weight, but it is distributed to all four limbs. And it's right at the fetlock joint. So this is how they get the horse from the induction stall to the surgery room. And here's a couple other examples of some padding. So these legs, see how they're separated now. Sometimes you can't do that scissor positioning depending on the surgery you're doing. But at minimum, they need to be separated. And you can see they've covered the hoofs. They still pick out the hoofs, but they just used actually shoe covers or sometimes surgical bouffants to put over the hoofs. And in this picture down here, this horse is in BD, and I don't know if you can tell that the legs are not stretched crazy. So a lot of times when people tie an animal down to a surgery table, I've seen some cats and dogs that look like they're on a torture table, like they've taken the legs and stretched them. In a dog and a cat, it's not as critical, but I never kind of really stretch them too hard. But in a horse, their limbs are usually better if they can just kind of relax. We don't usually like to stretch them out. So they kind of like to leave the limbs a little relaxed. In this picture, yes, they are bent. But in this picture, you can see the horse is just, there's like these brackets on the side that are preventing the horse from sliding one way or the other. So some notes under here, you have to have prominent nerves protected, make sure they're not on any hard surfaces, and we want to make sure it says in dorsal recumbency, the limbs are not tied. You want them in a neutral, flexed, relaxed position. So because sometimes the ties can put pressure on the nerves, and so you just have to be really careful. And is there any question about padding or positioning? Okay. So IV induction, it's in a stall, usually where they can, you know, if you saw that stall, it had a door gate that we could push against the horse. So, now in the field, that horse just did a free fall. And like Dr. Pohl said, we have no prediction kind of which way it's going to fall. But if you support the head, if you hold the head as they go down, they're less likely to hurt themselves. You have to be careful too. Their eye is very prominent. So if they're going to slide down a wall, you want to try to keep their eye away from the wall. And you want them to go down very quickly. That is the goal. Fall very fast. Don't go through excitement stage. That's why we do that bolus technique. And then they're going to get intubated, someone check a vital, and then now normally, like I said, there's normally a pretty big team working on the horse, because as anesthetists, we were checking the pulse, intubating, making sure the IV was okay. The surgery team was usually putting on the hoist and the straps, and they were taking care of that end, because you want to do everything fairly quickly. So normally there's a pretty big team inducing a horse. This isn't like a two-person function. Now, let's talk about how you intubate them. But this is, if you read this, it says inhalant induction via nasotracheal tube. You are not going to mask down an adult horse, period. It just doesn't happen. So there's no mask induction in an adult horse. Now, if you have a foal and they don't want to do a IV induction, now you can theoretically mask a foal, but you can also pass what's called a nasotracheal tube. And it's a very long, thin endotracheal tube, but they will pass it down the ventral nasal meatus. I've talked to you about that landmark before. You're going to go to the ventral nasal meatus and you're going to pass it all the way back to the trachea. So it's not going through the oral cavity. And then you're going to hook it up to a small animal machine, and you're going to inhale. Then they're going to inhale the induction. So instead of mask induction, like we would maybe do in a dog or a cat, you can do it nasotracheally, and they're going to inhale. And usually when you're doing this, it's probably a pretty sick foal, okay? So a lot of times, if they're a poor doer or they're having issues, they will tolerate this type of induction. If it's a foal, they look small, they're strong. So if they're going to resist and they're fairly healthy, they'll probably get some type of sedative. But you can do a nasotracheal inhalant induction. But let me talk about the standard intubation. So in an adult horse, you're going to use, pick 2 tubes. And again, the tubes are much larger. I know, like, usually the maximum we use in small animal is a size 14. Usually, we did have a 16 tube I used in a Great Dane. But most clinics go up to about size 14. Horses, we're talking 22, 24, 26 millimeter endotracheal tubes. So they're much longer and they're much wider diameter. Then you need some mouth gag, a 60 mil syringe to fill the cuff. Because if you use a 12 mil syringe, you're going to be there all day, because this is a bigger cuff. And you can certainly use a 12 mil syringe. It's just going to take several syringes. So we normally use a 60 mil syringe because it's a bigger cuff. And the same principles apply. Like when you put a little air in the cuff, you're going to get a little resistance when you hit the trachea, and that's about where you want to stop. Now, here's what the tubes look like. And one of the mouth gags, now in the video yesterday, they had a metal mouth gag that goes between their teeth and you can crank it and it cranks open their mouth. A lot of clinics will just have a chunk of PVC pipe, like that white plumbing tubing, and they've wrapped it in elasticon bandage material, and you can put that in their mouth and pass the tube through the pipe. So, and here's the syringe needed. Now, again, these are much longer tubes. Normal sizes, I've given you, 22, 24, 26, 30, there can be a wide range in there, but a foal is going to use a smaller tube, but somewhere from a 10 to a 14, which are usually small animal size tubes. But I will tell you, foal tubes, you need to get the longer tubes. So you would order that diameter, except you'd order a longer tube because they have a very long neck compared to a dog or a cat. And the one thing I want to say is length is not an issue. If you look at an adult horse from the tip of the nose to like their brisket area near, well, kind of where the neck meets the shoulders, that's about the thoracic inlet. And that's where the trachea bifurcates. That's really long. You don't have to worry about putting the tube too far. Remember, I've talked in small animal, you need to feel at the thoracic inlet, make sure that the tip doesn't go past. These tubes are usually just going to be put in, and usually you just leave a little bit out the end of the mouth, and you're usually not going to go past that thoracic inlet because horses all have a pretty defined length from their tip of their nose to their neck. You're not going to go past. So you don't have to check the thoracic inlet in a horse. Check the cuff, make sure it holds pressure, make sure they're cleaned properly. All of those apply. The nice thing about equine intubation, it is so simple. It is, so thankfully, because everything else is complex, but it is a blind technique, meaning you are not going to look back and visualize the larynx or the epiglottis. So normally what you do is, it's very rare to get it in the esophagus. So normally what you do is someone extends their head, so the horse drops to the ground. Someone extends their head, so you don't want it bent, but you extend it. Someone can grab the tongue and usually just pull it on the outside of the mouth, and you're just going to slide the tip, you're going to slide it in. If you meet resistance, then you're just going to back it out, give it another little twist. Now, if you pass it easily, you can, when the horse breathes, you're going to feel for air, or someone can go push on their chest and feel for air. That's how you confirm tube placement in a horse. So if I ask you, how do you confirm tube placement in a horse? You're not going to tell me you're not going to feel it in their neck. I promise you. Their neck is huge. Their trachea is very deep, and there's a lot of muscle. You're not going to be able to put your hand up there and slide the tube back and forth. So the only thing you're feeling for is air. And don't tell me you're going to visualize when you put the tube in, because you can't see back there. Their mouth is very narrow and very long, and you can't really see the epiglottis. So this is all done by feel. And when I mean feel, you're not also reaching back there and feeling. You're actually just sliding it in, and it typically slides into the right place. Normally you can tie the tube to their, a lot of times we leave the halter on, so you usually just tie the tube to the halter, or you can tie the tube like to the mouth gag. You can put a piece of tape around their muzzle or gauze around their muzzle, except you're gonna have to use a really big piece. So most people just tie it, and then you're gonna put some air in it, because again, you want to. Now horses, interestingly, cannot vomit. So they can't actively vomit, but you can sometimes get some passive regurgitated fluid. That's why as soon as you put the tube in, you do want to put some air in the cuff, because they're not going to be hooked up to the machine. You got to like hoist them, you got to roll them in. But when you do all that, you still want to have the cuff inflated so we don't get any passive regurgitation. Now, if you have a horse that is going to have surgery on the head or neck area, or something in the mouth, you can do nasal tracheal intubation in an adult horse. It is going to be a smaller diameter, than the normal endotracheal tubes. Nasotracheal, because think about this, their nasal opening is not as big as their tracheal opening. So this is going to have to be able to fit through the ventral nasal meatus and go. Now, nasotracheal intubation is going from the nasal passages all the way to the trachea. That's why it's called nasotracheal. And it has to go, and then it's going to give them oxygen and anesthetic while they're, doing anesthesia. You do have to worry, what's the medical term for nosebleed?
Epistaxis?
Epistaxis, yep. So, and don't tell me on a test they can get a nosebleed. You're far enough in the program, that's the word I want to hear. So anytime you're going to go through the nasal passages, like in a foal or an adult horse, one of the complications is going to be epistaxis. And usually it's self-limiting. It's not like, they'll bleed and then it'll start to clot up. But again, remember, a horse is an obligate nasal breather. We don't need a horse post-op having a whole bunch of blood clots obstructing their nasal cavity, potentially obstructing their ability to breathe. So there's very, when we do this, we have to make sure, this is the last resort. We have to intubate this way. So we do worry about epistaxis. Complication of intubation, you can always cause, vagal stimulation. You can always cause tracheal trauma. You can get it in the wrong place, but you just slip it out and try to re-intubate. But sometimes miniature horses are a little bit harder to intubate. And of course, obviously, if they have any oral or nasal cavity diseases, also any laryngeal paralysis that affects the opening of the trachea. So, and it says here, horses don't regurgitate during anesthesia. They're not vomiting. They're not doing the traditional regurgitation. But again, what I'm worried about is like this fluid kind of passively flowing up, and that's why you inflate the cuff. So I do want you, and the other reason, remember, the other reason you inflate a cuff is you also want to prevent leakage of anesthetic gas. So you're not only doing it, in a dog and a cat, you want to prevent vomiting, vomited fluids or regurgitated fluids from getting into the lungs, but it also is to prevent waste anesthetic gas from leaking, but it's never to hold the tube in place. And remember, you never want to put the endotracheal tube all the way in the mouth, because never, ever, ever do that. And this is just a very practical tip, and I want to say it, I'll say it 20 times, because if an animal wakes up prematurely, and this has happened to me plenty of times, and they're chomping, you may sometimes, now a lot of times you have to be able to like close the mouth. I've always given you that tip. If you don't want an animal to bite a tube in half and they're chewing, you can grab their mouth and hold it shut. They can't bite the tube in half. But I worry, if the tube is in the mouth, could they swallow it? Now, if it's tied, theoretically, hopefully it won't go down that far. But I always want to be able to grab my tube in an emergency if I have to pull that tube out. On recovery, a lot of animals chomp, and then they're getting more of their swallow back. So I always just make sure I have a little tube hanging out of my mouth. Most of the time in small animal, those tubes sometimes are long. You'll have a decent amount of tube. But if you've got like a German Shepherd or a Great Dane, or sometimes a bigger dog with a longer neck, sometimes the tube, you won't even feel the tip because the tube's not long enough. But I never bury a tube in a mouth. And you don't want to keep tubes on the side of the mouth. I see a lot of people hang the endotracheal tube out the side of the mouth. If that animal starts to wake up and chew, they're going to bite that tube in half. If you put the tube in between their canines going out their incisors, when they chew, they're less likely to bite the tube with their incisors. But if you're back between the molars, they can definitely bite that tube. So that's just a tip that if I've not stressed enough, because I mean, I will walk by and go in surgery and reposition a tube if I see it hanging out of mouth, because it's just, I've seen it happen, and you never know when it's going to happen because it can happen quickly. So just always have it out the front of the mouth. That's the safest place. Now, when we hook them up to their inhalant, you're going to have the same, you're going to calculate your oxygen flow rate. I will tell you, when we talked about isoflurane and sevoflurane, remember sevoflurane has the lowest blood gas solubility, so it's the quickest induction and quickest recovery. I've heard from some of my friends that work in large animal that a lot of equine vets are not fond of sevoflurane in adult healthy horses because they can wake up so quickly. When we recover a horse, we kind of want them sleeping a little bit. We don't want them necessarily like jumping right up. That's their problem, is they wake up too quick. So we like drugs that have a little bit of a hangover that keeps them asleep. So sevoflurane may or may not be used, and I think isoflurane is usually the inhalant of choice. Now, isoflurane is quick too. It's just SIBO is a little bit quicker. Now, if you have a sick foal or you have a really sick colic, maybe sevoflurane has an advantage because you can change planes. Remember, I talk about quick induction and quick recovery, but when you talk about inhalants, another advantage is being able to change planes rapidly. Like if you have them turned up too high and you turn them down rapidly, they're going to wake up, they're going to lighten up faster with SIBO than ISO. But it says right here, when you change anesthetic settings and oxygen settings, because you have such a large patient, it's going to occur a little slower. I always tell you guys, I think you turn a dog down with isoflurane, maybe 5-10 minutes, you're going to see a change. It kind of depends on the patient, how deep they are. There's a lot of factors, but that's just kind of a guesstimate. But it might be a little bit, 10-15 minutes in a horse, maybe up to 20 minutes. So, when you alter the settings, and usually when I do this, I realize maybe my horse is too deep. I have to turn them down. And sometimes I want them to change rapidly. It's not going to happen as fast in a horse. Now, on the flip side, another scary thing is you have a horse that gets light during anesthesia and they start moving. Well, there's no holding that animal down. So normally an anesthetist is always going to have some additional intravenous agent. Now, we don't use thiopental anymore, but typically some ketamine and xylazine, potentially some guaifenesin, but ketamine can be given IV, because again, if you just turn up your vaporizer to try and make them deeper, if they're moving, we need them asleep now. We don't have 10 minutes to say, oh, we'll let them get deeper on the inhalant. Sometimes you have to give intravenous agent during the procedure. And sometimes that happens in small animal. That I told you guys, and I'm not in surgery with you. Well, Miss Redmond's in there and she'll be great. But I never get rid of my leftover propofol. Remember I said sometimes you don't give all your propofol? It's always sitting in my pocket. Or I keep the bottle in my pocket, because if a dog does get light, or a cat during anesthesia, like very light, like moving or licking or chewing, I can give some of that leftover propofol IV and get them deeper quicker. Sometimes they get a little light, they huff and puff, I just turn up the inhalant. You're going to have somebody with you that's going to help guide you on what to do, but these are just options. But in a horse, turning up a horse isn't going to be like instant go back to sleep. So that's, again, the advantage of having some of that leftover inhalant if you have to. Okay. I'm going to stop there because I don't want to shove this very important monitoring stuff in these last 5 minutes because this is important. So I will stop here. Do you have any questions?
So Dr.